The next topic is syncope in children. We got an eminent speaker, Dr. Edwin Francis, Director and Senior Consultant Pediatric Cardiologist, Aster Medcity, Cochin. Over to you, sir.
So, syncope is, as you know, is a brief loss of consciousness associated with loss of postural tone with almost immediate recovery, spontaneous recovery. So it's a pretty common change. They say that between 15 to 20% of the children or pre-adolescent age group have an episode of syncope. So in the OPD, you almost always comes across one case of syncope almost a week or probably almost every day. The presentation can be quite varied, and then an unnecessary evaluation may result in more anxiety to the parents and to the kid probably. So that is what I want to stress upon. So most common cause, as you all know, it's an autonomic. Almost 80% or 80-85% is due to autonomic causes, vasovagal, situational, and orthostatic syndromes. Neurological causes like migraine, seizures contribute to another 15-20%, and then comes the cardiac is less than 1 or 2%. So why me talking on this area of syncope? The concern is the most life-threatening or treatable cause of syncope are cardiogenic. All others are just more of reassurance and speaking or counseling the parents. And these could be identification treatment, could be life-saving. Just clear classical history of neurocardiogenic syncope. You have a 14-year-old adolescent fainted in the school after the end of an assembly, recovered on her own and is fully conscious when evaluated. The key elements of history is the timing of the event, the activity leading to the event, associated symptoms, posture at the time of the event, the family history, and probably menstrual history. You have a prodrome, you have a loss of consciousness, and then almost immediate recovery. Neurocardiac syndrome, what are the precipitants which commonly relate to this disease or the problem? Is anemia, dehydration, hunger, viral or a noxious stimuli, which can precipitate, and the triggering events could be a prolonged upright posture, a cough, menstruation, or emotional stress which can trigger the syncope. This is a standard thing which you all learned in the physiology classes, the basal-gyrus reflex, which causes a parasympathetic stimulation which results in the loss of consciousness by bradycardia and vasomotor dilatation. You all know it is related to the mechanoreceptors and the baroreceptors, and there's a lot of jargon here. I don't think anybody understands it, but the exam you can blame the baroreceptors anytime. It will all be safe and nobody can question you. There's another problem is like a syndrome is a postural orthostatic tachycardia syndrome, which is more often seen in teenage girls. It's present with dizziness, palpitation, or anxiety. It is diagnosed as an excessive increase in the heart rate, more than 40 over the baseline in children, or more than 30 or more than or goes above 120 in adults, especially on statin. This can be duplicated in the heart test or the heart head-up tilt table test. Again, this is a pretty innocuous thing, just reassurance alone is required. Coming to the cardiac causes which you are concerned about are the electrical disturbances, structural, or other few rarer causes. The electrical disturbances, as you all know, the most common could be the long QT syndrome. And the rarer ones are Brugada, which is more often seen in the adult age group, familial tachycardias, pre-excitation WPW, and bradyarrhythmias are also not so uncommon in the pediatric age group. The structural abnormalities which can result in a syncope include a hypertrophic cardiomyopathy, an erythrogenic RV dysplasia, we call it ARVD, a valvular aortic stenosis, or other congenital heart disease which can result in a syncope or a pre-syncope. The rarer other cardiac causes include coronary abnormalities, post-Kawasaki problems, or could be a dilated cardiomyopathy. It's rare to present with syncope, even though it can happen, and pulmonary hypertension, even though there's a lot of written about it, but then usually they have other symptoms before they present with syncope. I'll give you another case scenario here, like a 3-month-old, 4.8 kg normal saturations. He has an episode of choritachycardia at day 3 of life, found to have done an echo and shown to have ASD, and was reassured and sent home. Now again referred back to us with another episode of choreseizure, loss of consciousness, with no family history of any specific diseases related to it. There's an ECG, and PGs are there, they can make out You can see there is quite easily evident. You have another 2 P waves here. I don't know if I can have. You can see 2 P waves here. It's a 2:1 AV block, and more importantly, you can see that the tall waves are the T waves. You can see a long QT here. So it's a 2:1 AV block with a long QT. So as advised admission Holter monitoring was done, which showed a polymorphic VT, hence we start on beta blocker. And on beta blocker, the heart rate remained 50 to 60 because of the 2:1 conduction and with no hypotension. This was on beta blocker. You can see the heart rate has come down a bit with 2:1 and long QT persisted. So this is the tosadis which is seen in the Holter monitoring done, because this was the cause of the syncope of this kid. So long QT, I'm not going to the further details, not an area which at this point. So long QT, the most common ones are one is the autosomal dominant one with the Romanov-Ward syndrome, which is have a purely cardiac phenotype, and a more severe malignant form is an autosomal recessive, the Jervell-Lange-Nielsen syndrome associated with deafness. So this is another ECG, is another cause for a syncope. I think you can make out it's a very short PR interval and a delta wave, WPW, can result in SVTs, result in syncope. But again, most of them come with palpitations. A syncope again is a rare event of a WPW syndrome. So coming to the evaluation, obviously as you all know, it's basically a detailed history and a clinical examination, all that is required to diagnose a vasovagal syncope. And investigations when and only it is required. That is where the real problem happens. We are in a real world. You can see here 113 patients were evaluated. Only 4%, nearly 89 got investigated. 4% contributed to any diagnosis. Nearly 57 CTs were ordered. And 11 admission, again, was due to incorrectly interpreted ECGs. So that is data from the Western world. Obviously, we don't have much hard data from this subcontinent. So what you need to be careful about are the red signs. Red flag are the syncope on exertion and a syncope which is occurring on a supine position. A patient known to have a heart disease, obviously you take it seriously. Past history of a Kawasaki makes you need further evaluation. A sudden death in the family, a cardiomyopathy in the relative, or a known arrhythmias in the family, or deafness makes you evaluate further. ECG, I probably in this era, which is not completely in our course, not expensive, an ECG could be done on almost any patient who walks into an OPD. That's all I would ask for, other than a detailed evaluation, including history and clinical. An echocardiogram or a heart test or a head-up tilt-table test, Holter, EEG, or a CT should be kept only for those patients who really feel that they need to be further evaluated. Otherwise, it only creates more confusion and anxiety to the parents. Again, the question of the head-up tilt-table test is again, it's quite controversial. Some people quite often do that, especially the neurologists. And these are the studies, again, which shows there are varying sensitivity and specificity varying from 50 to 80%. So there are many people who say that it is quite useless because it doesn't give you anything. It is not diagnostic. It only to give a further confirmation of your clinical diagnosis. So if it doesn't happen, negative or positive, it doesn't give you any major thing. Only thing, if it heart is positive, you can say there are no major other illness, and you can probably reassure the parents more comfortably. And what are the real advantages of the heart test? It does probably clarify the diagnosis or confirms it. Always allays the fear for the parents, and it can be given as an educational tool to give you the preventive measures to them. It lacks uniformity, non-diagnostic, not predictive outcome, and not always reproduced. And how do you want to manage them? It's almost always education and reassurance, avoidance of the triggers. We provide them more salt and water. Sorry for the nephrologist. Here again, water. In very limited time, we advise a cardiac patient to have more fluid. So it's a very rare situation in which a cardiologist advises more fluid, and exercise to improve upon the calf muscle tone. These are the very simple maneuvers which could be done, which can almost always could be more effective than the drugs many a time. I'll come to that later. So this is, you just keep on this, ask them to stay on the toes. When you stay longer, on the upright position longer in assemblies, all the other situations, on the school or in the church. And this other stress pattern, crossing the legs is found to be very often useful, or you have a clenching your fists on both sides. It also helps you to prevent, if you have a prodromal symptoms, you immediately do this, or you don't wait for that 15-20 minutes, you're standing there longer, you just do this every 15-20 minutes, you can prevent them. Coming to the drugs, only a very small percentage is going to be useful. These are the beta blockers which are known to be useful, which has been almost all textbooks give that, but none of the trials have shown this beta blockers to be effective. Only the studies which have shown a marginal benefit in those patients who are more than 40 years. Obviously, it's not come in our area. So, adults which can be useful, but in pediatric age group, the beta blockers, mostly propranolol or metoprolol, is not known to be effective. Then comes the alpha agonist midodrine, which is the most often prescribed drug, which is around 2.5 to 5 mg twice a day. But still, again, there is no evidence. I'll just go to that drug in the next slide again. Next drugs are the serotonin inhibitors and the mineralocorticoid fluticasone. All are used, but again, the effectiveness are quite dubious. Since this is a study in the prevention of syncope trial, which was studied to look into the effectiveness of the beta blockers, but the trial never could prove a benefit with the beta blockers. I just thought I'll just show, I was reading this book last year. This is a Bart Pharma, sorry for my pharmaceutical colleagues in and around the hall. But this author is a Ben Golder, it's I think it's from UK, as a psychiatrist. And I just remember that in that book, it just clearly mentions this this midodrine, which is a drug which came from a company in 1996. Even after 14 years, there was no clear evidence for the FDA to continue to approve it. But then went back by the time, the company said that it doesn't care because already the patent laws have done 10 years, so they don't get any benefit. So they went on. Even then, when the FDA went to stop the licensing of this drug, there are many patient support groups came up and said that it is quite effective. But till now, beyond 26 years, still we don't have a clear evidence. So for a few more words on the cardiac causes, the treatment of a specific cardiac anomaly is quite important. If you have a structural problem seen, obviously you need to intervene there. A long QT, you know there are different treatment like avoiding the precipitating factors, the drug induced, you avoid that. You have beta blockers could be useful, a cervical sympathectomy. If there is a smaller child, an older kid, you can do a pacemaker implantation or an ICD insertion. There's the same baby after the cervical sympathectomy. You can see the long QT interval has improved, use 1:1 conduction, and baby is still doing well. And for structural anomalies, you do the specific treatment of specific cause. And to conclude, syncope is generally a very benign event, and the history, physical examination, probably an ECG is that all is required. And then a detailed evaluation, those with history of sudden death or a syncope following exercise is quite needed. Thank you.
Thank you, Dr. Edwin, for the elaborate presentation. Any questions?
I would now like to request our chairpersons to present a memento to our speakers.